Hello, welcome everyone. I am so excited to kick off this showcase today. We have an incredible group gathered, including many of you who have come to hear today's innovators. So thank you all so much for taking the time to join us. By way of introduction, I am Wendy Taylor. I am the Vice President for Technical Leadership and Innovation at Jhpiego. I also, before joining, spent several years working alongside the Rockefeller Foundation and a number of people on this call to think about how do we modernize our global epidemic intelligence systems to prepare for future pandemics. So this is a personal passion of mine, but I've also been a fan of the Trinity Challenge since it first launched, and that's why I'm particularly pleased that Jhpiego, through our Worldwide Innovation Support Hub, or the WISH platform, has had the privilege of spending the last year providing targeted support to the 8 winners of the 2021 Trinity Challenge. And for those who don't know, the Trinity Challenge is a global prize competition that called for innovations in data and analytics to help the world better identify, respond to, and recover from pandemics. And so today we are so delighted to give you a glimpse into all of the progress they've been making since they first received their prizes. So we're going to hear from them. We have a series of 8 lightning talks that are going to be focused first on surveillance and response, and then we're going to focus the second section on prediction and early warning. And we're going to give you some time to ask questions after each of these. But first, to open today's event, it is very much my privilege and great honor to introduce Dame Sally Davies. She is Master of Trinity College, University of Cambridge. She is the UK Special Envoy on Antimicrobial Resistance. She's also chair of the Trinity Challenge, and I think has really been the force and inspiration behind this really important innovation effort. She has a long list of accomplishments, which I don't have time to go into, but please check out her bio. She is a remarkable leader in health, both in the UK and globally, and we're enormously proud to welcome her here. Dame Sally Davies, over to you.
Thank you so much, Wendy. And I want to welcome winners, sponsors, colleagues, and friends, because it's such a pleasure to come together with this wonderful showcase celebrating the success of our inaugural Trinity Challenge Prize winners. Note the inaugural. And we're going to hear progress and how we can go on supporting the winners in their goals. I want to acknowledge the role and say thank you to those who were the Trinity Challenge founder members, funders and partners. You made this challenge a success, and thank you for continuing your support. And my thank you to Jhpiego too. You've heard our vision in 2021. It was about safeguarding the livelihoods of people across the globe by setting this new global challenge for the world, using data and analytics to better identify, respond to, and recover from health emergencies. I think that in doing so, we demonstrated how strengthening those data analytics and learning ecosystems can drive positive change for global public health, and how the power of multidisciplinary partnerships can be harnessed in the search for answers. The solution to mitigating and responding to pandemics lies in collective, collaborative action, finding solutions. We know that, we see it. Although today we're celebrating our winners and their progress over the last couple of years, I also want to acknowledge the 330 other teams from 60 countries who put in applications. There was inspirational work, and it was formative in trying to find solutions to the second, and we pray the last, though it probably isn't, pandemic of this century. Just 12 days ago, the WHO Director General declared an end to COVID-19 as a public health emergency. Days later, similarly for Mpox, public health emergency of international concern too. Yet at the same time, he correctly highlighted we still don't know the true number of daily deaths from COVID-19 due to the lack of optimal surveillance systems. So COVID-19 may be over as a global health emergency, but clearly it's still a global health threat. And we can't let our guard down. The ever-present threat from influenza viruses, coronaviruses, the next great pandemic remain, as does the pandemic potential of Ebola. After all, the latest outbreak of Ebola in Uganda was declared over after taking 5 months As climate change and destruction of our environments continues to take their toll, the risk of spillover events from animals to humans continues and actually accelerates the likely appearance of disease X. And that's why we at the Trinity Challenge focus on predicting, detecting and responding to future pandemics. And that's why the work's so important, needing innovation from everyone, just as we're going to see today, protecting people, food security, and actually our planet's health. Whilst all eyes are on predicting the next pandemic, we as a global community are all too ready to ignore pandemics that are ongoing, and for some of which innovation in data and analytics are going to be critical to turning the tide. Over the last couple of decades, many of you know I've championed a call to action to mitigate the grand pandemic of AMR. And I'm delighted to announce that AMR, antimicrobial resistance, is the focus of our next, the second Trinity Challenge. Fleming, at his Nobel Prize speech, said that the time may come when penicillin can be bought by anyone in shops, and then there's a danger that the ignorant man may easily underdose himself by exposing his microbes to non-lethal quantities of the drug, make them resistant. That warning from Fleming was prescient. Over the years we've had antibiotics, they've been overused and misused, leading to the spread of antibiotic-resistant bacteria. And AMR, particularly bacterial resistance to antibiotics, is the quintessential example of a One Health challenge. It threatens human health security, animal health security, and by that, the food chain, environmental security from pollution, from antibiotics, increasing resistance in environmental bacteria, and a global threat by potentially destabilizing geopolitics with the loss of global common goods. The Graham report from the Institute of Health Metrics and Evaluation has helped us to quantify the problem through estimation of mortality and morbidity. Most of you will know their work, finding that in 2019, close to an estimated 5 million deaths were associated with bacterial AMR, and nearly 1.3 million people died directly as a result of bacteria resistant to antibiotics causing their infections. These are the lowest likely numbers and don't include AMR from malaria and HIV as well, for instance. However, the true magnitude of deaths from AMR is still unknown, largely due to the lack of proper surveillance and access to diagnostics to identify bacterial infection and resistant profiles. AMR is this prime example of a wicked problem, one that is complex, persistent, and multifaceted, difficult to define, understand, and solve. And these complex wicked problems like AMR are characterized by their interdependence, uncertainty, and multiple, and as we know, often conflicting perspectives. Wicked problems like AMR are deeply embedded in social, political, economic, and environmental contexts, making them difficult to address. AMR as a wicked problem is an opportunity for innovation and creativity, and we need more. And so that's why the new Trinity Challenge on AMR means we're going to be looking to innovators like all of you and beyond to step up and help find solutions through novel data and analytics to answer a critical gap in knowledge and our understanding how data from communities in low and middle income countries relating to antibiotic resistance and other AMR use or access and quality can inform action. The Trinity Challenge on AMR is going to focus on data from low and middle income countries, out of hospital, and across the One Health spectrum. Thank you, Wellcome Trust, for coming in as our original anchor sponsor and funder. We're seeking innovation in the types of data collected and analytics used, integration of current and new data sets with perhaps citizen-related data to broaden our understanding of transmission dynamics of resistance and access pathways. and how innovations in data and analytics can lead to the implementation of more effective policy interventions. So we're going to celebrate the success of our first challenge winners from the Trinity Challenge, and I'm planting with all of you the seeds for you to innovate for our next grand challenge on bacterial AMR. And now I hand over for our first set of lightning talks from our awardees focused on surveillance and response. Thank you.
สวัสดีครับ I am going to present about PODD, the Participatory One Health Disease Detection. The problem we are addressing is the lack of community participation in disease outbreaks, detection, and response, which is lead to unable to achieve timely pandemic prevention at its start and shortage of global preparedness for the next pandemic. Our solutions is, number one, the PODD system approach, which enable early detection and rapid response of animal and human disease outbreak. It provides real-time notification and informatics to manage incidents right at the first outbreak place. Number two, the ready-to-use open-source basic PODD software, that is a One Health Toolkit, which is accessible for any interested parties. The project part one, the ongoing PODD surveillance system in Thailand. We are providing choice of 18 features covering major community One Health issues. Why do we provide the community choice and co-creation? Because outbreaks occur a few times in a year, and no working system would survive just for 2 to 3 times uses in a year. To limit the system only on pandemic interest at the community level is therefore not sustainable in the real world situation. We prepare ourselves to be ready to share and support the inventing and community co-creation know-how, of course, with our implementing experience. And we initiated a smart safety community network. About the success and challenge to consolidate PODD users in Thailand by realizing the community owned the system which responsive to local needs. To date, about 400 out of 8,000 local governments utilize the PODD system for their own interest. This is 300% of the project target, covering 2 million people. We got 50,000 reports in the past 6 months. Out of this, the potential outbreak of 96 episodes in animal and COVID-19 10 episodes and 55 episodes of dengue could be prevented. Part 2, the One Health Toolkit. We are providing 8 features of basic One Health reporting software, emphasizing animal health surveillance to avert pandemic, which is now available in English and Lao language. Number 2, we also provide the One Health learning series for general public to learn and try out the PODD system. The One Health Toolkit is accessible from the website. Part 3, implementation and application in other countries. We are piloting PODD system and One Health Toolkit in Laos through trainings and implementing the system. And we are exploring other potential communities in other countries to try out the surveillance system and tool. Our frontiers is to expand the system within Southeast Asia and the opportunity. We are going to apply the PODD feature of non-communicable disease, which got the Prime Minister Award this year for the sentinel surveillance of infectious disease. And we are looking to apply the PODD participatory guarantee system for the surveillance of animal disease and antimicrobial resistance. We need the funding support for scaling in Laos and expansion in Myanmar. And we seek partners to work with us on the public health authority in those countries. Thank you very much.
Hello, and welcome to the presentation on Vaccine Ledger. As global public healthcare leaders and large donors, you're committed to resolving public health issues and looking for innovative and cost-effective solutions that can increase transparency, reduce waste, and improve outcomes for vulnerable populations. Vaccine Ledger is the platform that can help you achieve these goals. We saw the problem of inefficiencies and waste in vaccine supply chains, where 1 out of 4 vaccines get spoiled before reaching beneficiaries, resulting in inefficient vaccine delivery programs. This issue is not only affecting vaccine distribution, but also resulting in billions of dollars of losses for the biopharma industry. We recognize this dual problem very well, and we're committed to leverage it in creating a solution that is both socially impactful and financially sustainable. Our innovative, incentive-driven business model rewards supply chain stakeholders for actively participating in capturing product quality and quantity data throughout the supply chain, which increases visibility for biopharma industry, prevents losses, and reduces vaccine waste. Our platform leverages the unique QR codes that are mandated by various governments and printed by vaccine manufacturers on each unit of vaccine packaging to capture data at a unit level in the supply chains. We decentralize and automate the incentive mechanism using blockchain technology, which ensures the security and transparency of data while creating a win-win situation for supply chain stakeholders and biopharma companies. We have successfully deployed Vaccine Ledger in Costa Rica, onboarding nearly 1,500 locations and creating 65% market visibility. Our platform has helped to prevent waste, increase efficiency, and improve outcomes in the supply chains. We have also demonstrated the versatility and adaptability of the technology by creating Unify Aid, a platform that tracks aid for women and child welfare development in India. Unify Aid leverages the same incentive model to reward last-mile health workers to capture proof of delivery to the beneficiaries, which increases the accountability in aid distribution. We are excited about the big opportunity to scale Vaccine Ledger to about 28 countries by the end of 2024. Our platform has the potential to create lasting impact in a variety of settings and industries, and we are committed to ensuring that all stakeholders have access to the benefits of our technology. We are seeking your support to expand our deployments and scale our platform. We need mentorship, private capital, and connections to help us achieve our goals and create a more sustainable and resilient future for vaccine supply chains and beyond. Thank you for your attention, and we hope that you are as excited about Vaccine Ledger as we are. Our platform represents a cost-effective and innovative solution for improving vaccine supply chain visibility, reducing waste, and improving outcomes for vulnerable populations. With your support, we can create a more equitable and sustainable future for all stakeholders involved.
Hello. Firstly, I would love to convey our thanks for your interest in our showcase today. I'm called Dr. Stella Kanyerere, the Deputy Country Director for Living Goods Uganda. For those of you who are unaware of us, Living Goods is an international NGO that's partnering with governments to strengthen and scale impactful models for improving health outcomes through community health worker-led strategies. We focus on saving lives at scale by supporting digitally empowered community health workers, ensuring that they are equipped with skills and essential commodities, supervised and compensated. Desk-enabled CHWs demonstrate high-impact results at scale. Preliminary results from an RCT in Uganda show that the desk approach can reduce under 5 mortality by 30%. Last year alone, Living Good supported 12,000 community health workers to reach 6.7 million people with life-saving interventions. Of these, 3.5 million were sick children under 5 who were treated or referred. CHWs have also proven to be a powerful resource to ensure health systems are responsive and resilient to the increasing threat of disease outbreaks and the challenge of maintaining routine health services during these times of system-wide disruptions. During the COVID pandemic and the recent Ebola outbreak in Uganda, desk-enabled CHWs maintained essential health services to the most vulnerable and supported households through screening, health education, and uptake of preventive measures. We see that in 2020 alone, Living Good supported CHWs were able to maintain health services to over 8 million people and saved nearly close to 20,000 lives. One of the most critical consequences of disruptions that are caused by pandemics and outbreaks is to routine immunization. Between 2019 and 2020, globally, there's an estimated 67 million children who are either partially or completely missing out on routine immunizations due to the COVID-19 pandemic. The goal of leaving no one behind is yet to be achieved. The world needs to innovate and come up with proven solutions to reach zero-dose children and missed communities. Thankfully, desk-enabled CHWs are a powerful tool to improve last-mile vaccine demand uptake. And we see that in our past year partnership with Gavi and the Ugandan and Kenyan government, over 6,000 CHWs significantly increased demand for immunization. We saw this improving by 36% in Uganda and 69% in Kenya, and the number of zero-dose children identified falling across that 2-year project period. Living Good is continuing to prioritize and innovate on reaching zero-dose children and missed communities. Through our support from the agency fund, we are now part of the Precision Health Partnership, which is a consortium of organizations that are using predictive analytics to address health challenges that have a huge potential to improve healthcare access and outcomes for those who are most vulnerable and marginalized. Our focus has been to develop an algorithm to identify children who are at high risk of defaulting on routine immunizations. Our internal data validations have produced an algorithm that is 90% accurate, and findings suggesting that attributes such as religion, wealth quintile, maternity history are significant predictors of vaccine defaulting. As such, our ambitions are to test this in our real-life setting through integrating it into our CHW programming work in Uganda and in Kenya. So our ask for today is in 3 areas. Firstly, we are seeking investment as a collective of organizations working on the different use cases for predictive analytics to further expand this work and deploy pilots. The partnership overall is seeking a 2 million investment, but funders can consider investing in the partnership as a whole or supporting Living Goods alone for an amount close to $700,000. Secondly, Living Goods is seeking a $600,000 investment and technical support to take the next steps in developing a community-based disease surveillance system that will leverage on the power of community health workers. Finally, in Kenya, we are currently exploring the application of virtual strategies and telehealth integrated into CHW-led systems to create more efficiencies, better coverage, and responsive data-driven approaches to access and uptake of health services. This, we are seeking an investment of $700,000. Many thanks for your time, and we are happy to take any questions that you may have.
My name is Ruchit Nagar, and I'm the CEO and co-founder of Khushi Baby. Khushi means happiness in Hindi, and it's our goal to spread health and happiness to millions of families across India. In order to do this, we make digital health solutions for community health systems. We work as the technical support partner to the Department of Health of India's largest state, Rajasthan, which is home to 80 million people. Our focus centers around the community health worker. Bharti is a community health worker shown here. She spends her days visiting 10 households, 10 of over 1,000 households in her village, keeping track of over 12 primary healthcare vertical programs on a mix of paper and digital systems. She is burdened by incentive schemes that do not encourage disease reporting and delayed remuneration. But a digital transformation can change this and bring value to the data that Bharti collects and acts upon every day. Our approach is by implementing Jhpiego, the Community Health Integrated Platform, which is a unified offline mobile interface for longitudinal care coordination across India's primary healthcare verticals. It brings together Bharti, the community health worker known as the Asha, with her nurse and medical officer who sits at the primary health center to coordinate on care of their beneficiaries. Jhpiego has been scaled up across the state of Rajasthan. Over 70,000 community health workers have been onboarded. They've used Jhpiego to reach 40 million beneficiaries and identify over 3 million beneficiaries who are at risk. What's next for Jhpiego? Well, we're really excited to be powering up Jhpiego with a suite of solutions that we call Kushi AI. Kushi AI includes both solutions in machine learning models specifically for detecting individual level risk and community level risk. We look to augment the community health worker's smartphone with image-based biomarkers for detection of anemia and tuberculosis. We look to implement early risk predictive models that can identify which pregnant women are likely to have poor infant outcomes. We have geospatial models that we've developed that map out village-level multidimensional poverty, and we're looking to layer this with other climate-related health datasets to understand the burden of disease, especially as it relates to climate-related factors at scale. And it's not enough to know where the issues are, but also which interventions are actually working in those localities, which is why we're introducing A/B testing for health interventions at scale. Finally, we're building a synthetic open data set for global public health researchers to collaborate upon while preserving patient privacy. To accomplish these goals, we're raising $3 million to help us scale our platform across Rajasthan and India through 2026. This represents the total amount that we've raised over the last 10 years. And in fact, our solution compared to other peers is 15 times more cost efficient and has reached twice the number of beneficiaries than other platforms and similar low and middle income countries. In fact, the government of India, for reference, has also invested $13 million for smartphone and data plan incentives for scaling up the Jhpiego platform in Rajasthan. So this is a worthy investment, and it needs to be looked at as an investment in digital health and health system strengthening for India. So we invite you to join us on this journey to bring Kushi to 1.3 million community health workers like Bharti across India and over 1 billion rural beneficiaries who they are being supported by. Thank you so much.
All right. Well, that was fantastic. Thank you to our 4 amazing innovators. And so now we get to dig in a little. And so I'm very pleased to bring onto the screen with me Dr. Mark Smolinski. He is president of Ending Pandemics. He is also long recognized as really one of the world's leading experts on disease surveillance and outbreaks. So we're very lucky to have you here with us, Mark. And so just for a few minutes, we wanted to ask you, you've listened to these 4 innovators. We would love to hear some of your reflections. What excites you about what you've seen? How are some of these innovations filling gaps or could really move the needle forward around surveillance and response? So over to you, Mark.
Thank you, Wendy, and greetings to all. As we heard from Dame Sally's, the aim of the Trinity Challenge was to uncover solutions that use data and analytics in novel ways to better inform decision-making and guide responses to future outbreaks. Clearly, all 4 of the solutions we just had a glimpse into with these videos highlight why each of these systems are winners of the inaugural Trinity Challenge. Let me offer my personal congratulations to each of you. I look forward to see the full potential of your solutions as you become successful in achieving the partnerships to meet the asks that you have put forward to the virtual community joining us today. I was asked to just make these few brief remarks before turning the session over to questions and comments from the audience as you engage with this incredible group of innovators. A few common elements are readily apparent from these video presentations. All of them are applying technology in creative ways to solve very complex and often long-standing health challenges. Some of the impacts shared are quite revealing in lives saved, but also in the improvement of overall health for families and communities and the preservation of livelihoods. These impacts range from the astounding number of outbreaks prevented by PAW-DD in finding threats first in animals so that humans remain uninfected, thus potentially saving the world from another zoonotic pandemic threat like SARS-CoV-2. To the heroic efforts of Vaccine Ledger to reduce the $35 billion annual loss to the biopharma industry as 1 out of 4 vaccines gets wasted in the supply chain. To the impressive reduction in under 5 and infant mortality by the community health workers supported by the digital empowerment of living goods, some of which is no doubt attributable to their efforts to increase vaccination rates within their communities. And finally, to the efforts of Cushy Baby to spread health and happiness by pushing the boundaries of what is possible with today's smartphones and the integration of data to share with researchers for the greater public good. All of these successes are also met with some collective ideas by all of these systems to expand beyond the detection and response to disease outbreaks, to incorporate machine learning and apply artificial challenges like chronic diseases, environmental health, and to track the distribution of aid. Most of these solutions are also dedicated to educating the public, which COVID has shown us is a great need, while at the same time partnering with governments, which is essential for preventing and responding to disease outbreaks. Dr. Lertock's comments on PAW-DD being a community-owned system responsive to local needs that looks at 18 types of community health events so it operates at all times and not just during health emergencies is a critical message to take to heart, as this will allow each of these systems to flourish and expand to meet the numerous challenges before them as sustainable solutions. And we should all heed these words of wisdom as they are coming from the grand prize winner of the inaugural Trinity Challenge, and deservingly so. But all of you are winners, each bringing a unique set of talents, passion, and innovative approaches to change the world for the better. So again, congratulations to all of you, and I'll now turn it back over to Wendy.
Excellent. Thanks so much, Mark. Really nice reflections. Also, I'm really glad you mentioned community-owned as being an important piece of this, and we know how much community ownership, country ownership is critical for adoption, but it's just also important for getting it right when we think about scaling these solutions. So we're going to turn now to the Q&A. We have a quick rapid fire opportunity for questions from the audience. So everybody get ready. Please put your questions in the chat. Mark, I'm going to give you the honor if you want to throw out at least the first question before we start bringing in some others from all of our participants who are listening today. So please start firing away your questions in the chat. We'll get to you in a minute. Mark, over to you.
Okay. Thank you, and it's good to see all of you live after watching your faces on those incredible videos that I know is hard to condense messages into 5 minutes. But all 4 of your solutions presented today really rely on the active and willing participation of community agents, whether they're community health workers, farmers, or other members of the community. Can you each talk about how you're mobilizing and incentivizing communities to participate in your system? You know, essentially, why do they want to work with you?
And I'm going to ask the respondents to be super, super fast, a minute apiece.
May I go first? At first, we engage the mayor, and then we train them how to use the app, and let them and help them to expand this to their community. And in our cases, it's quite easy because we right now we use like WhatsApps, so everybody can use this technology. So it's no problem to use the app, and we just convince them that to report the abnormal event to the system. Thank you.
So I'll go next. What we have introduced in our app is basically automated incentives. So every time a healthcare worker scans a product and informs us about the quality, quantity information, and also records the proof of delivery of the product to the beneficiaries. So they get rewarded and basically in the app through reward points. And these reward points, based on the ecosystem, can be exchanged for, in some cases, cash, or in other cases, could be some other products that the ecosystem is offering, right? So this provides a real incentive for active participation, and we also provide those incentives to the beneficiaries also for self-reporting. So the beneficiaries also benefit from reporting about whether they have received the aid product, whether it's vaccines or could be any other product, right? So when they record that they have accepted or they have received those products, they get similar points, and this kind of encourages everyone to actively participate and provide more accurate data in the supply chain.
I'll go next. So for Living Good, we are working with community health workers who are locally known in Uganda as VHTs and in Kenya as community health promoters, who are part of the national health system and are usually referred to as the Health Center 1, which is normally the first contact that some communities have to the healthcare system. So we are supporting them to be efficiently supervised, to be equipped with, continuous capacity building for their skills to be up to date. We are to run opportunities, but also we are very big on the use of data for driving efficiencies. Thank you so much.
And from Cushy Baby standpoint, working with the community is essential to what we do. 25% of our team comprises of field monitors that work every day out of the week, side by side with community health workers. We've co-designed our community health integrated platform after spending over 180,000 collective person hours working side by side with community health workers. So it's very important to have that field level perspective, but also we take a macro level perspective as well, and we advocate for community health workers in terms of helping draft budgets, so that way community health workers can be supported by their automated incentives, so that they can pay for things like data plans and smartphones that are required to run this program.
Excellent. So I don't see any questions in the chat yet. Please, I know that you have lots of questions running through your mind, so please, I encourage you all to jump in with questions. I know Mark has a whole slew of them, so he's prepared to jump in again. Mark, would you like to throw out another question to our group here?
Yeah, so this question I think actually could go out to everyone again, but I was specifically interested in when I saw the video on Cushy Baby about the open data set for public health researchers. What I'm wondering is, in addition to the data coming in from your individual systems, how are you integrating that with other data from either the country or the region or other organizations working within your ecosystem to really broaden your sort of situational awareness, if you will, beyond the data in your own single system?
No, it's a great question. The clearest example of this has to do with our work on the intersection between climate and health. So we are looking at publicly available climate-related data sets, whether that's land surface temperature, rainfall, vegetation, light index, air quality index, to see how those spatially relevant factors interact with the local spatially mapped health outcomes. We are also seeking partnerships with organizations like the Public Health Foundation of India, who have made very, very detailed spatiotemporal maps for things like air quality index, and at a village level resolution. So we're trying to incorporate data sets that are kind of globally accessible. And then the other thing that we're trying to do, like you mentioned, is make a synthetic data set for public health researchers. And what this means is taking our data, not just de-identifying it, but making certain perturbations to the data, making some transformations to that data so that it's a different data set. But it's still, if researchers were to analyze it and try to derive insights, those methods and similar insights could be applied and kind of cross-applied to our local setting without having to expose any patient's private data. So we're trying to make a public health data bank, just like you might see with other biobanks around the world.
Excellent. Well, we have a number of questions that are starting to come in, so I'd like to turn to those. And so we've got a question from Ben Pine at Skoll. Thanks, Ben. So the question is, sometimes the way that the world speaks about pandemic prevention can be extractive. So he said Mark's questions shed light on this as well. So in your work, how do you all think about protecting clients' rights to their own data and countering any extractive practices in this space? Who wants to take that?
So it's more about, the question is, if I understand it right, it's how do you ensure data privacy for beneficiaries in the last mile? So that's actually very important, because in our case as well. So what we are basically recording today is we're tracking a vaccine throughout its journey, all the way from the manufacturer to the end beneficiary. Now, so the most of the supply chain data can be public. So this includes what type of, how many vaccines are where, what type of vaccines are located in what locations, how many are getting spoiled, how many are getting delivered, how many are expiring in various locations. All this is very useful data, and it's good for this data to be public. But when it comes to last mile, and when you're recording which vaccine went to which beneficiary, so over there, I think having being a little more cautious is critical. So what we have basically recorded so far is only like age and sex of a person who is receiving the vaccine, and nothing more beyond that in terms of personal data. So that ensures that, hey, we're not capturing this data more than what we should. But there is a new technology that has evolved, which is called zero knowledge proof. What zero knowledge proof does is basically you can have all the data, even the data that beneficiaries are sharing through the app, on one platform, but without actually looking into the data, there's insights that can be that can be derived without going into individual data. So there's a whole science behind it, but it's getting extremely popular. And that's something that we're working on right now.
Excellent. Well, I have a related question on this, so I'm going to ask this one. And so if somebody else wanted to respond to that, they can build off of this one. I'm also there's another question here. So I'm going to give two. We only have a minute left, so we'll have to be super fast. But Mandy Govender at Transform Health asked the question saying, building off of this, she's keen to understand what, if any, measure, including principles, are being used to govern the data being collected from individuals. So data governance is quite important. So someone can take that on. And then also the question for Living Goods is, what are the core skills that you train healthcare workers with in terms of digital literacy? So maybe 25 seconds each. Who wants to take the governance?
I can jump in for governance. So India has a new concept called Ayushman Bharat Digital Mission, in which patients are the owners of their data. They also can give permission for specific data to be shared. I think patients need to own the data, and over time, digital literacy will improve, and we can help promote that. At the same time, it's important to make sure we have strong consent processes, and that the patient and community health worker relationship can be strengthened as well.
Excellent.
If I can jump in quickly
Please.
to respond to the question for Living Goods. So the core skills in terms of digital literacy that we are training the community health workers on starts with basic, how do you handle a smart gadget? How do you power it? How do you maximize its battery? But also specifically into the app, we are training them on how to use the application offline and online, how they're able to sync that data on a daily basis onto the servers, and generally how they are able to go through the different workflows that are in the platform. So it could be basic, but sometimes because of the cadre that we are working with, we take close to 2 days or 3 days during the onboarding processes to take them through this digital literacy of how to use the digital tools.
Excellent, excellent. Well, we are at time. That's 12 minutes goes super fast. Thank you to our speakers. Thank you to the audience with your questions. So we are going to move into our next session. Feel free to stretch your legs. We're going to transition over, but we will be moving right into our forecasting and early warning lightning talks.
I'm Professor Kate Jones, and I'm the lead for the Sentinel Forecasting Project. So our team is solving the problem of how we can predict and manage the risk of animal diseases jumping into humans. And as we've seen from the COVID-19 pandemic, these diseases have severe global economic and health consequences. The pandemic also really focused global attention on how human disturbance of natural ecosystems drives these disease outbreaks. But this fact has been neglected in most public health responses to date, and this siloed thinking severely limits the ability of our public health systems to predict and prevent future outbreaks. So we need a much more integrated One Health approach to understanding disease risk that links the knowledge of the ecology of the animal host or the vectors to how many people are exposed through our use of the environment with the vulnerability of these human populations. Of course, all of this sits within this dynamic framework of global change where climate change and land use change act on all parts of this system. So until we really integrate and bring together all these different silos, we will not be successful in predicting spillovers. So West Africa is a really critical nexus of these issues. And following one of the biggest outbreaks of Lassa fever in 2018, I began working with colleagues in the Nigeria Centre for Disease Control, the NCDC, to use this interdisciplinary One Health approach to understand outbreak risk. However, our initial models were pretty limited to the most data-rich areas of Nigeria, and it was really unclear how best to incorporate these models to inform decisions by the public health managers. Funding from the Trinity Challenge really helped transform our approach, both in the scale and ambition. And our team that we've put together for this project crosses these disciplinary silo boundaries and unites data not just from ecology and from climate change and environment, but also with cutting-edge genomics and epidemiology. And we've been co-developing with the stakeholders involved a real-time forecasting system for public health agencies in West Africa, starting with Lassa fever. So we're also utilising data from existing and new surveillance systems in Nigeria through Christine Happy's Sentinel project, which we're operationalising into a interactive predictive user interface in collaboration with Microsoft. So far with the Trinity Challenge funding, we've been working with the NCDC to set up their systems to pull epidemiological data and Earth observation data together to improve our modelling accuracy for Lassa fever, both in space and in time. And because of the strong link to climate that Lassa fever has through its rodent host population biology, the model can forecast risk 1 to 3 months ahead. We've also been talking to the stakeholders extensively, and we held our first multi-stakeholder colloquium and a series of workshops in Nigeria a few weeks ago. And through that, our team has a much better handle on the most pressing research and policy gaps there are for Lassa fever, but also we did a situation analysis to see the strengths and the weaknesses of the NCDC data and their responses to understand how the forecasting platform tool could be of most use. So we're now putting the first draft of that platform together with our colleagues from NCDC, but also London School of Hygiene, Tropical Medicine and Microsoft for the first user testing. So there's some really exciting prospects for this work, which could be realised with further funding. So, for example, support for more targeted epidemiological surveillance to ground truth the models in areas where they're not currently performing as well as we'd like, but also expanding this type of modelling for Lassa fever across the region and or for different diseases like Ebola or Mpox. And lastly, we heard some really powerful testimony at the conference from Lassa fever survivors, and particularly from a young boy who had survived Lassa fever but unfortunately lost his father to the disease, because mostly I think because of diagnostic confusion with malaria, and by the time they figured it out it was too late. So it'd be really fabulous to see if we could start to develop some AI symptom diagnostic tools which were informed by our models that could be deployed at the front line to really help with that diagnostic confusion. So thanks very much, and happy to answer any questions.
Hello, my name is Mike Roberts. I'm going to talk about the Blood Counts Consortium, one of the previous prize winners of the Trinity Challenge, and give an update on our progress so far. And obviously, thank you to everyone for organising this today, particularly the Trinity Challenge and any of the partners here. So just to recap, what was the ambition of blood counts? So we aim to use complete blood count data, so the complete blood count being the most common clinical test in the world, at scale to predict and track pandemics and other health emergencies. And why do we want to focus on complete blood counts? Well, as I said, it's the most common clinical test, a 3.6 billion per year across the globe, and is absolutely essential for decision making in the community and hospital care to allow for triage of patients and likely diagnoses. But only 2 to 3 measurements are used on a patient-by-patient basis to make these decisions. And inside the machine, we have high-dimensional rich data that are recorded for every sample. And if we apply AI to these high-dimensional data, we were able to detect the SARS-CoV-2 outbreak in Cambridge. And this rich CBC data that is already paid for, but is usually thrown away, is of immense value for public health surveillance. So why does our solution work? Well, infection causes profound changes in the characteristics of the immune cells in the blood. And these changes can be detected by our analysis of this rich CBC data. And we can identify signatures unique to different pathogens. And our technique is completely pathogen agnostic, with no prior knowledge of a specific bug needed for outbreak detection. And thanks to how lightweight the algorithm is and how small the data packets are that are needed, it can be scaled to very resource limited countries very easily. So the Blood Counts Consortium would be nothing without our partners, and we have really lucky to have a group that spreads from Europe through Asia, Africa, and this really gives us a diverse data set, but also a diverse thinking in how we apply the algorithms. So we need to be able to apply these algorithms in very resource limited settings as well as high resource settings. So on to our progress to date. So after the award was announced and negotiations with the university completed, we managed to recruit the entire team by April of 2022 and then start our analysis. And this analysis of the CBC data led to the foundation of our consortium workshop, where we got all of the blood count partners across the world to come to Cambridge, and we really figured out what are the problems we're trying to tackle, what is the deployment scenario in the different countries, which countries need particular ethical agreements and data collection agreements before they could start. And since then we have also put together an ethics document which was approved last month. Very excitingly, this allows us to start analysing the data across UCLH, BARTS and CUH here in the UK, and this ethics is going out to all the local partners across the globe. And finally, our next step, so we'll be continuing building the collaboration with our existing international partners and taking in new partners. In addition, we'll be getting local ethical approval at far more sites across the globe and starting data collection at those that we haven't already. We'll be building, critically, the federated learning infrastructure across the different sites in the Blood Counts Consortium. There are 2 publications here which are coming out in the next month or so. One is around combating the inherent biases and issues with machine learning using CBC data at scale. And then the second is a review of federated learning methodologies and come out with the best practice for using federated learning in the way that we want to use it as well. And then we can follow that best practice when we build our system. And our ask to everyone here is just 2 simple things. So one is advice on long-term capacity building for the project. We have a lot of problems we could tackle and a lot of partners that we could enroll in the project, and just understanding strategically what would be important for us and what approach should we take. And then anyone with expertise working with low and middle income countries for data projects will be invaluable to us to understand any future long-term deployment considerations we need to make. And I thank you so much for the invite to talk today.
My name is Asif Kasim. I'm the founder and CEO of MedShare, and I'm really pleased to be giving this update to the Innovation Showcase about MedShare's Insights and Early Warning System, which has been supported by the Trinity Challenge. We launched MedShare in 2015 with a really specific mission to empower doctors and healthcare professionals to use their own smartphone to capture, share and discuss clinical cases. MedShare has grown rapidly since then and now has over 2.5 million members in 195 countries, using the platform primarily for clinical case discussion and peer-to-peer learning. And those case discussions reflect their real-world medical practice and the clinical cases that they see every day in the hospitals, clinics, and other places that they work. We're unique in that we've got a global reach, particularly into low and middle income countries, and MedShare has been described by Sir Tim Berners-Lee as a unique repository of medical knowledge. When clinicians come to the platform, they see something that's familiar because we've used the best of social network technology to connect clinicians with one another and empower them to use this global network to learn from one another. What that means is that we've got this universe of real-world medical information about the conversations that doctors are having. So from the cases, the comments, the polls, and the discussions and the votes, we've got a huge amount of MedShare data, and it's a unique data set. What we've done with MedShare Insights is develop medical natural language processing and AI algorithms to extract clinical insights from those data. So we know exactly where any healthcare term on the platform has been used, its context, and what that applies to across different trends and times. Developing the early warning system is an extension of the MedShare Insights platform to see if we can identify infectious disease outbreaks and detect new clinical insights around infectious diseases. So from a technical point of view, we used a version of the MedCat trainer to develop our medical natural language processing that allowed us to train and learn from existing clinical cases to annotate and recognize terms in this informal medical text and conversations that we had, referenced against the SNOMED CT taxonomy and RX norm drug name database. Developing from that initially therapy areas and disease-based insights, going on then further to look at further trends. In terms of that medical natural language processing, it's a named entity recognition model that starts with a creation of these concept databases that are then turned into supervised and unsupervised training to develop deeper insights from the platform. In terms of how we then reference that, we use, as I said, the SNOMED CT taxonomy and RX norm branded drug names so that we can see what's being used on the platform and cluster related concepts together so that, for example, we capture all the references to a specific term, such as COVID-19, from the variety of different clinical SNOMED CT taxonomy terms that may be used. We've turned these into engaging data visualizations that can be explored by clinicians and clients. And to start with, what they see is a bubble map that shows the terms used around a specific therapy area with the size of the bubble reflecting the frequency of use. They can explore this and they can look at the intersections between terms and then look at how they range over time and in different geographies. So, for example, you could look at COVID-19 specifically around the symptoms or the treatments, or at how it intersects between different parameters across that whole data set that we have. Moving on from that, what we're able to do is to look at the emerging terms around a specific disease area. So these are terms that are increasing in frequency over a specific period. And likewise, the trending terms that have looked like they're increasing in frequency and already being mentioned within the context of that therapy area. We're just starting this journey. We've made great progress so far in developing MedShare Insights. In terms of the next steps, we're looking, of course, to always increase our membership and case discussion because this increases our depth of data. We're keen to work with partners in global health education to extend that reach further. We're seeking additional funding so that we can continue the work on the early warning system and develop those insights further. And as well as that, we're also looking for partners with additional data sources so that we can develop infectious disease insights and mapping models so that we can build out the early warning system to give real value to clients and partners. Thank you for your attention, and thanks again to the Trinity Challenge for their support.
Hi, we are the Descenda team, developing a disease surveillance tool using a multimodal sensor network combined with data analytics. Our team is a partnership between the University of Massachusetts Lowell, Northeastern University, and the University of the Philippines. As the COVID pandemic has shown us, disease outbreaks exert tremendous health and economic burdens on societies. We need readily available and real-time health data to prevent and contain such outbreaks, but a real challenge is that getting these data is unfortunately very slow, often sporadic, and costly. The type of data generated can also be variable across regions and potentially even non-existent. Now, what if we could detect outbreaks before they spiral out of control and cost lives and livelihoods? Our Descenda team has developed a wireless sensor network that offers a surveillance solution that rapidly detects pathogens in both air and sewage, even before cases present and rise in populations. Continuous passive monitoring and real-time data streaming, analysis, and visualization then allow public health officials in these communities to make critical life-saving decisions. At the core of our system are two patented sensing technologies: the acoustic wave sensor for wastewater detection, which uses a bioprobe array that can be custom designed to detect any pathogen and is easily attached to the sensor using a replaceable and cost-effective film sticker, achieving high specificity and sensitivity for pathogen detection. Our other device is the eNose air sensor, which can monitor and rapidly detect pathogens in the air, using pathogen templates that are easily imprinted, also achieving high specificity and sensitivity. Sensor measurements that are output from these two devices are combined with other demographic and environmental data such as human mobility, weather, and health reports. We use machine learning to identify emerging disease patterns or outbreaks. The results can be integrated into public safety alert systems and platforms for reporting back to community leaders or to inform public health decisions and advisories. Our team of student and faculty researchers have spent the past several months developing our sensor technologies. We have conducted tests in various confined spaces and field visits with potential industry partners. We are working on building handheld prototypes for easy and versatile deployment by non-experts. And we are testing and optimizing protocols for different pathogens, environmental conditions, and infrastructure contexts. We believe that Descenda is a game-changing surveillance system because it is low cost and can be deployed in remote and vulnerable communities that have limited access to health services. Our monitoring device can be used in small, medium, and large-scale community settings. It can be designed for tracking other important diseases related to public and livestock health, such as the avian flu and cholera. Our sensor network is a team effort of researchers across multiple disciplines and organizations. Our team of students and faculty has made tremendous progress with very little seed funding, but we need investment support for our researchers, for building prototypes, for pilot deployment, and for expanding our capacity to test sensor applications of other diseases. At Descenda, we believe that investments in people are investments for the future. Thank you.
Okay, well, that was another fantastic round of talks. Thank you to our innovators. So we heard a lot about forecasting and early warning. I can't think of anyone better to bring into this conversation than none other than Dylan George. Dylan is the director for the Center for Forecasting and Outbreak Analytics at CDC. This is a new innovative center. Dylan is a longtime friend, collaborator, and co-conspirator, and honestly, he's one of the smartest people I know. So Dylan, I would love to hear some of your thoughts. If you could give us a few minutes of reflections on the innovations that you've just seen and why they're important, how they could really lead to some real impact. Over to you, Dylan.
Thank you, Wendy. It's always a pleasure to be with you as well. As Wendy said, it's like I'm the inaugural director of the Center for Forecasting and Outbreak Analytics at the United States CDC. We are the newest center at the CDC, and it is lovely to be with you all today, and it is absolute honor to be with the groups that are building these new capabilities for fighting outbreaks and pandemics. Thank you for the opportunity to be here with you all today. I don't think it's a surprise to anyone that technology has clearly transformed our world. We can see hyper-local weather forecasts to guide our personal decisions on a day-to-day basis. From the gig economy, we can order rideshare transportation, and we can know by the minute when it will arrive and where we will arrive at our location going forward. And so we have a plethora of information at our fingertips in a range of different settings. Unfortunately, technology hasn't transformed healthcare or public health in a similar or comprehensive way. Because of this, we do not have the same type and quality of technology or information at our fingertips to promote or protect our health. And this becomes, quite honestly, frustrating. But also, this is an exquisite opportunity. I and many of us on this call believe that data and analytical technologies can be a major force for good in outbreak responses. I would even say that data for action will be the vaccines of our generation. And what I mean by that is that it can have data, if we use data effectively for action, it can have the same impact on the order that vaccines have in public health today. This is why I'm super excited about the Trinity Challenge and generally, and the specific projects that has been funded and the people that you just saw right here. Early detection allows for early response in an outbreak. We all know this, and anticipating what's next is a pressing need for helping responses be ready and effective. And so this set of presentations has demonstrated a range of capabilities, data, and efforts to anticipate what's around the corner during a public health emergency event. And so that's why I think it's really exciting. So congratulations to all that have participated in efforts and successes that are going forward.
Great. Thank you, Dylan. I always find it so inspirational. I mean, I think this is why we're all here. I think this is the inspiration behind this challenge of how do we start using these data and these new capabilities around analytics to solve these big, and to quote Dame Sally, these big wicked problems. So with that, I want to open it up to questions. Dylan, I'm going to give you the first honor to ask a question, and for our audience, start throwing those questions in the chat, please. I'm sure you have many. So Dylan, over to you first.
So everyone, this is a question for everybody. In this segment, you all introduced some really compelling sorts of novel data sources or approaches of analyzing new data sources to give us early warning, either on pandemic threats or healthcare needs. Could you talk each of you talk a little bit about how you have collaborated with public health authorities to operationalize these capabilities for use in public health? And or what are the support do you need from public health to really operationalize these decisions going forward?
Can I go first? So I think the really key aspect of that question is to work with the public health authorities from the beginning, and to do co-development with them. So really trying to get to grips with how decisions are made and understand how your tool could influence those decisions, and making sure that the authorities are in the mix of those conversations right at the beginning.
Just a comment from me around where the MedShare starting point was that we wanted to work directly with clinicians and have a very direct contract between clinicians engaging with one another and the really close link to their patients. So for us, that starting point then subsequently led to working with other organizations, whether it's healthcare providers, national specialist medical societies, and others. So in some ways, we've done it the other way around. And certainly from a point of view of the insights that we're developing and so on, we're providing, for example, any outputs from the early warning system, free or at very low cost to public health organizations, NGOs, and others. But absolutely agree with Kate that the sooner that you can collaborate, discuss, and understand what's important and also how you can collaborate, you can align much more quickly.
So if I could answer also that, I totally agree that developing these tools, you need to collaborate with your future partners. So two things we've done with blood counts is for advocating the need for such systems like ours, but also any of our fellow panel members. We've also included things like the UK Health Security Agency, just having conversations with them and inviting them to our workshops and being very open about the tools we're developing and to understand how that could be fitted into the structure. But we're also very much aware that we need to provide thorough scientific evidence that what we are proposing will work, will actually work, because creating a hype without a backup or objective goals is not good. That will not go down well in the public, especially since we're talking about data sciences and large data. People are always a bit worried for the right causes. So I think one of our biggest goals is to make sure that we have very robust, validated data before we further connect to these agencies. And we definitely will, but a little bit of caution is always required just to be sure that the scientific basis is there.
So I'll add to that a little bit. So this one is a little bit different from the other members of this panel, because we are working with environmental data to kind of map that out with the health data. So for us, the conversation starts from where we are piloting the Sendas. So we're piloting it with COVID surveillance and COVID data. So the introduction to those who are potential partners, whether it's from public health or from those who are leaders of the community, is a little easier when we approach it from introduction, saying that we have sensors that are capable of detecting pathogens in water and air, but we actually have data to show that it works for COVID. And so the conversation is easier because everybody now at this point knows that, hey, you can use your wastewater or your air data to know that you have pathogens that are in the air. And then we actually explain what are the other capabilities, and we show some data that we are able to look at Jhpiego as well. We can be tailored for our diseases like cholera. So in that sense, we tailor our conversation for what they know now, and then they actually ask us to, at least for the ones that we have talked with, they're not engineers like ours or anything, but they ask us, can you develop this for our animals too? Can you actually do this for that? So the conversation starts there, but also gives us, from the descendant point of view, it gives us an idea of what are the actual needs of the community and how do they actually envision working with our system for what they need it for.
And this is a question, this is the last question, then I think there's a couple questions in the chat, but it's like for our colleagues at MedShare, it's like you spoke about your network of it was built to try to improve the clinical treatment and could potentially be used for outbreak warning. Could also your network be used for helping to identify supply chain challenges or shortages in different capacities, as well as people are talking about the different treatments that are being used in your network?
Yeah, absolutely. I mean, what we cover a whole span of things. Our starting point was peer-to-peer learning, an area that we've moved into where we put a lot of energy now is into educational programs. So we've done a lot of global health educational programs. And certainly what comes out is not just the clinical challenges that people face, but also the austere environment challenges that people face. And so one way that this played out for us was that very early on in the COVID-19 pandemic, from April 2020 onwards, we were getting a lot of feedback around the challenges in low and middle income countries with prospective large numbers of COVID patients, limited supply to ITU, ventilators and oxygen. So we worked with a whole series of partners to look at both how we might respond to those challenges, so playing those out to NGOs, and at the same time running education programs around best practice COVID education with modifications for those austere and resource limited environments. So whilst our sort of our core is around peer-to-peer learning, sharing knowledge, improving healthcare, Dylan, as you rightly identify, lots of other things come out in those conversations as well. Where we can respond, we can, but we then try and play that out to other organizations that are better placed to help.
Super. Yeah, go ahead, Wendy.
Oh, sorry, Dylan. I'm going to hop over to some of the questions in the chat. So we've got two that have come in for blood counts. So I'm going to combine those. So first of all, can blood counts help to distinguish bacterial, viral, and malaria infection? And then also for you, if you could just quickly answer a question around informed consent. So how do you obtain informed consent for using blood of patients for detection beyond the purpose for which they provided the blood for a CBC? And if you do identify an infection using this blood, how's that information given back to the individual who provided the sample? So two questions quickly.
Those two questions. So first of all, yes, we can see different signatures for viral versus bacterial, and we're looking into malaria. And again, with more data, we will be able to validate that. That's why also the network spans the globe, so that the system can learn from locally endemic outbreaks to understand what that signature looks like. The second question is about ethics. So the ethics is not a patient individual level, so it's for aggregate data across the institutions. So we will collect, and we are collecting the data across a hospital or hospitals, but the data will be analyzed in a anonymized fashion across all of those patients. So we've had engagement with the public and patient organizations to understand if they would be okay with that. And they said yes, if it serves the bigger good. Will we at a point go back to the patient? Well, in the future, if we get these refined signals and we detect something earlier than their clinician would know, we would, but we're not there yet. But that would be obviously a follow-up project. We're very keen. We're also looking at other signals because this is such a rich resource of data, which we hope to employ for early detection of obviously pandemics, but also other diseases, which would improve the health of our patients.
Excellent. And now I've got a question that really can go to any of you, particularly those who are a little bit further along. But can you talk a little bit about how you are working either with local, and then when I say local national medical societies or local or national health organizations? Those are going to be critical for buy-in, uptake, ensuring that your solutions are being designed to meet local needs, community needs, national needs. So, and any thoughts on how you're doing that now, where you may be facing some challenges? And I've paraphrased the question a bit. So who wants to tackle that one? And then Dylan, I'm going to come back to you potentially with more questions.
I'm happy to comment initially on the partnership side. We work in lots of different ways with healthcare providers, medical societies, and groups of doctors with specific interests, primarily on supporting them around education and engagement. Sometimes we provide services for them on a client basis. Sometimes we provide platform services for them. There's a range of different models that we have in play for that, and certainly for the early warning system work that we're doing, the aim is to do that at very low or no cost. For some of the educational stuff, we've got a contractual arrangement that is a bit like a learning management system approach. But certainly there are lots of organizations that dovetail in with the work that we do that also leads for us into that push towards generating more conversations to get better depth of data, because for us the depth of data gives us more insights and more localized data within countries. And just one note on that is that in countries where the healthcare infrastructure is perhaps more disrupted, we tend to have more organic MedShare membership. So places like Yemen, DRC, we've got higher proportional membership than we do have in some other places.
Great. Dylan, do you have a question for some of our earlier stage forecasters? We want to just squeeze in quickly, last minute.
Yeah, no, Kate, you talked about how you're using a range of different sorts of data in kind of like a One Health context to better understand how to predict and operationalize forecasts for Lassa fever. Can you talk a little bit more about what is the range of pathogens or transmission modalities that these sorts of approaches would be most amenable to?
Thanks, Dylan. I guess quite a few modalities really. So vector-borne is ideal really for some of the models that we have, but also a number of other zoonotic diseases like Ebola or Mpox, yellow fever, other kind of diseases are really amenable to this platform. And the way that we've designed it is very modular. So you can add in those specific bits of the transmission pathway as you need. So you can drop that in into the portal, but then you've got access to all of the Earth observation data or vulnerability data of the local human populations as well. So I think it's very scalable to different diseases and modalities.
Excellent. Well, unfortunately, our 12 minutes went pretty fast with this group as well. So I will have to wrap up this segment, but just want to thank you all. Really appreciate all of your thoughtful responses. Thank you to the audience for sending some good questions. And so now I think we're just in the final stage of the program where we're going to wrap up here. But thanks to our panel. So we've heard so much over the last 90 minutes. I hope everyone is equally excited about both the progress and the potential of these innovations. We heard from Mark that a lot of these surveillance innovations have the potential to leverage advances in technology to solve complex and long-standing challenges, including even finding the possibility of finding threats first in animals and stopping outbreaks at their source before they spill over. We heard from Dylan that the innovation, some of the data and analytics, including some that you have heard about today, can be a force for good, and in fact can even be the equivalent of vaccines for our generation. And I can't think of anything more inspirational than that. And so really, I think this gets now to, I'm kind of turning to you, to the audience. We all know that the innovation journey is long. It's a challenging one. We've got a lot of exciting innovations here, but even the best innovations need help ensuring solutions meet market needs. They can get woven into health systems and really done in a way that can ensure effective scaling. And there's a lot that goes into that journey. And really, this is where you all come in. And so we encourage you you heard a lot of asks today, places where each of these innovators have said they're looking for some help. So we encourage you to engage and provide support in many ways. And of course, everyone is always looking for investment. That would be no surprise. But I think there are ways we can think about in-kind support. You heard about interest in partnership and mentorship and advice. You heard about interest in getting doors opened, making those connections that are necessary to move these innovations forward, including we've also even heard about needs for data access and much more. So lots of ways for you all to help. I wish we had all of your faces on the screen right now, because the wealth of access, ideas, knowledge in this collective space right here is tremendous. And so we look to all of you to be our partners, be the partners for Trinity Challenge along this innovation journey, and find ways to help realize this tremendous potential. So here's a few brass tacks here. The portal that you have access to is going to remain live for the next 90 days. So you can all return to that portal, get access to the awardee profiles, contact information is there. You may reach out to these innovators directly at your convenience. But also, we have a quick poll that we're going to put up. So if you saw anything that piqued your interest today, we encourage you to complete the quick poll that will pop up on your screen, and that will you'll be able to let us know some ways that we can follow up with you based on your preferences. So again, we invite you to be partners with us, help ensure that the best ideas do come to fruition. They are successful, they get to market, they are scaled, so the global community is better prepared to detect respond with more precision, predict, even prevent outbreaks and pandemics in the first place. These are all things that we know are coming our way in the future. We collectively have an opportunity to really make some big advances here. So thank you all for joining us today. Thank you to Dame Sally Davies. Thank you to Mark and Dylan for joining us, all of the innovators. Really pleased for all of the progress, excited for what's to come. Thank you again, and have a great day.